Thank you, everybody. Let's go ahead and get started. Appreciate everybody's time this morning. We're at a pivotal moment right now in healthcare. With the passage of HR1 in July, there are sweeping changes to Medicaid policy, work requirements, eligibility, redetermination, retroactive coverage limits, the provider tax and state-directed payment changes, and then changes to the tax credit expiration for the ACA. And all of these have significant impact on one, the Medicaid beneficiaries. And we'll talk a little bit about how some of that burden has been shifted to the beneficiaries and what that may mean for coverage churn for health systems. It also has significant impact, especially in those organizations that have provider tax and state-directed payments on their overall operational and financial sustainability. And so I'm joined today by several of my colleagues from Coker. We'll let each of them introduce themselves. I'm Dan DeBehnke. I'm Senior Vice President, Chief Physician Executive at Coker. I describe myself as a recovering emergency physician. I spent about 30 years of my career on the provider side in health systems and hospitals, leading large medical groups, CEO of a academic health system, and then have spent probably the last 7 to 10 years as an advisor to hospitals and health systems, helping them work through changes related to their operations, transformation, strategy, partnership, all those areas. I'm joined by my partner, Paul Weintraub, who I'll turn it to in a second. We lead Coker's performance transformation practice together. Paul, would you like to introduce yourself and give a little background?
Sure, absolutely. Paul Weintraub, Senior Vice President at Coker, approximately 25 plus years of experience leading transformation for health systems, everything from strategy down to operational redesign within a specific department or at the hospital level.
Pat?
And I'm Pat Wulf, Senior Vice President at Coker over the revenue cycle practice. I've got more years of healthcare experience than I'm going to admit to. Before I joined Coker about a year ago, I had a small boutique consulting firm for about 25 years. Previous to that, I had leadership positions at Capgemini, Ernst& Young, Humana, and also played COO of a rev cycle outsourcing firm. Most of the work I do is helping organizations, all kinds of different sizes, around their revenue cycle performance, leveraging data analytics to really understand where their opportunities are and where they're leaving money on the table. I've also led several projects on implementing EMRs, new rev cycle systems, so Epic, Cerner, even some of the small ones, Meditech, Allscript experience. I've got a degree in health system engineering from Georgia Tech, who's playing great football this year, thank goodness, as well as an MBA from University of Louisville. And I'm active in HFMA and do a fair bit of speaking for AHLA and some other organizations. And Brantley, I'll turn it over to you to introduce yourself.
Sure. Thanks, Pat. Brantley Kilgore, I'm Vice President, leading the strategy practice within Coker's Performance Transformation Group. I've been in the strategy consulting space within healthcare for almost 15 years. And a lot of what I focus on is centered around what we call enterprise revenue optimization or payer strategy and revenue rebalancing at the enterprise level. Also do a lot of work around physician alignment, incentives, and driving meaningful, valuable partnerships between health systems and physicians, largely on the independent side of the house. We also do a lot of work, and we have years of experience in the value-based care enablement and implementation space. I've built over 50 clinically integrated networks through my career. I've worked with over 100 ACOs in terms of how to bring the right capabilities to bear in order to succeed in that reimbursement environment. And then we also do a lot of service line and enterprise strategic planning as well. Recently joined Coker, but again, after 13 years or so, excited to kind of share some perspectives in response to what we're seeing in the market today related to HR1. Dan, I'll kick it back over to you and let you get started here.
Sounds good. Appreciate it. And thank you. Thank you guys for joining. There is, significant, hospitals and health systems right now are working on razor thin margins to begin with. And the changes that are coming from HR1 are going to put significant amount of stress test on those health systems. And so what I'd like to do is really, use the expertise of Paul, Pat, and Brantley here to tease out some key components to help you, hospitals and health systems, you as leaders, prepare for how you might want to weather this storm that's coming down the road. I'd like to start with a poll question. If we could launch the first poll question. Wow, it actually works. So the poll question is, which of the following is your organization's top priority over the next 12 to 18 months? And while that's cooking behind the scenes, I'll just give you a little introduction to Coker. You've heard it from several of our panelists. We're a advisory services firm, been in the business for about 35 years. We're based in Atlanta, Alpharetta, actually, and we really have four main areas of focus. One area is transaction advisory, where we're working with organizations as they're choosing partners or are being sought after as a partner, and work through the things related to valuation, et cetera, related to those type of transactions, both hospitals and medical groups. We have a very robust regulatory compliance and audit practice that works in those areas in the complexity in medical group and hospital and health system compliance. A health information technology practice that focuses on both the ambulatory space, so ambulatory electronic health record, and also the acute care space, looking at optimization, tech stack optimization, vendor choices, all of those things in the HIT space. And then, as we talked about, Paul and I lead our performance transformation practice, where we really help organization work through the challenges around maintaining quality and safety while driving financial and operational stability. Do we have the results of our poll? Ah, good. Interesting. Very evenly balanced workforce productivity, access, value-based care, and operating costs. Almost pretty equally balanced. Great. All right. Well, that helps to drive some of the questions. So Brantley, I'm going to start with you. The Commonwealth Fund did a study and put out a report recently looking at what the anticipated effects of HR1 might be. And really what they found was that they're projecting an 11 to 13% on average reduction in operating margin for hospitals and health systems, with rural and safety net being probably hit the hardest and probably the ones that can't absorb that. So my question to you is, given these different hospital and health system personas, safety net, rural, large IDNs, what are the differences that you see with respect to how HR1 might be affecting them, and perhaps how they might position themselves differently depending upon their situation?
Sure. Yeah. Yeah. Thanks. Thanks, Dan. And I think you hit the nail on the head. Everyone's going to feel the impact of this bill at some level, but the degree to which it impacts, day-to-day operations, strategy, and your ability to kind of come out on the other end in a better spot than we were before is certainly going to be largely impacted by how you're oriented and then the size of your organization. So, to your point, we expect our rural facilities to be hit the hardest. We see them as the most vulnerable provider organizations as a result of the impact of this bill. There is still sort of the potential for relief through the federal funding through the Rural Health Transformation Program. We're still waiting to figure out exactly how that's going to play out. Right now, we know there's $50 billion available that's going to be ultimately awarded at the state level. And then the question will be, how does each state then determine the recipients and the awards that will then be distributed at the provider level? Really, what we see from a worst case scenario standpoint on the rural side is that you're looking at potential for service line cuts, conversion of inpatient to outpatient, or closure entirely. I'm located in the state of Kentucky, and through that study, I think that Kentucky was projected to be one of the hardest hit states. So that's certainly something that I've been seeing, hearing, and talking with a lot of folks here locally about. But I think the last point I would make from the rural perspective is I think one of the biggest things that we need to be aware of and planning around is the real risk of access deterioration, right? How does that then affect our ability to provide care at the community level? So from a rural standpoint, a lot a lot of uncertainty, unrest, risk, but there's the potential again that for some relief from a federal perspective.
Great. Thank you.
One thing I might add to that is also just Medicaid expansion versus non-expansion states. That has a huge impact in combination with everything that I think you just outlined, Brantley. I think those states that are Medicaid expansion are going to be significantly impacted, disproportionately more so than those that didn't expand prior. So that's something that we definitely have been looking at, as you noted, Kentucky, California, New York. I think there's 40 states that are going to be disproportionate. And there's also like this, I don't know through your guys' conversations, but I'm hearing sort of a bifurcation of those systems that are financially strong in non-Medicaid expansion states are actually looking at expansion opportunities in this time also. So that it's not all, it's interesting because it's not all doom and gloom for everybody. There is some opportunities for expansion and growth for those who are already well positioned financially to take advantage of this opportunity, I guess, from that standpoint, while others are really needing to put a plan together going forward.
And, I mean, Paul, one of the things we're going to have to see is just the disparity in the marketplace. As Brantley talked about with the rural hospitals, one of those falls, and the uncompensated care that was delivered by that hospital falls to the other rural hospitals around there, just, expanding their burden. And you think about it from a rev cycle side, one of the things we've really got to tighten down is our eligibility requirements. So, do I really have any kind of Medicaid coverage? Do I have any kind of insurance coverage? We're going to see some of the differences with the Obamacare subsidies as well. And so we're going to go back to where we were after the 2008 recession, where all of a sudden the uncompensated care uninsured levels are increasing, which is just going to tackle our margin. So now, I've got to make sure my rev cycle performance is going to be really much more optimal in the front end to get that registration right. And that starts to set up some of what you're talking about. If I'm a healthy player in an interesting marketplace, can I, by really improving my front door, steal some of my competition's paying patients? So, within some of the storms, there are sometimes the crystals of, goodness, but you really got to be strategic to figure out how to go ahead and do that.
Yeah, yeah, thanks. And actually, Pat, I want to unpack that revenue cycle side of things a little bit. So some of the components that are in HR1 are really target eligibility. So, I mean, significant changes in eligibility requirements and eligibility redetermination. So shortening that eligibility redetermination from now a year to 6 months, and also some of the retroactive coverage. So historically, you were able to, bill a Medicaid patient for 3 months prior to their eligibility. Now it's only 1 month. So what we've seen, and I know you know this better than I do, when we've seen changes to Medicaid at the state or at the federal level, and when we've seen changes, so let's say with the ACA, and we put this burden of administrative proof on the beneficiary, we see a lot of what I would call almost procedural dropout of eligibility. People just couldn't get their eligibility taken care of. So there's this churn. People are dropping in and out of coverage. What's the impact of that on the rev cycle team, specifically that front end? And what can organizations do on the front end to be able to prepare for that from a verification of eligibility and all of those sort of components?
So, the interesting thing is through the COVID, issues, et cetera, we got, all these longer approvals that you didn't have to do quite as much work there. And for the most part, I know of very few of my clients that have their Medicaid eligibility in-house. This is typically an outsourced operation. So now you think about it from the process perspective, you're talking about, Dan, I got to make sure my handoffs are crisp. So, I'm, trying to verify any kind of coverage for you. I can't find any. I answer the first couple questions and say, you may be Medicaid eligible. I've got to hand you off to the vendor and make sure I get that over there and get that taken care of quickly. So a couple of things, you've got to look at that process and how you've got it designed. You've got to decide, do I still want to have this outsourced because it's going to become much more critical in terms of my success? And if I do keep it outsourced, one of the things that we see with most of our rev cycle clients is 15 to 25% of my dollars are collected by somebody else, vendors somehow involved in my organization. And yet I don't manage them as aggressively as I should have or should. And so now with the new eligibility requirements, it's going to be critical that I can't let time lag. If I give you a patient to make the determination, we've got to have service metric or service level agreements in there that says you've got X days to go ahead and get that, process started. You've got Y days to get the determination for me so I can figure out, am I going to get paid or am I going to have to put you into some kind of uncompensated care program? So all aspects of that front end become much more critical. And you think about it, yeah, 30+% of my admissions come through the ER. I don't have the ability to do that proactively. But that says 70%. I've got a shot at doing something proactive, and I need to make sure I'm doing that now.
Good, good. Appreciate that. Let's launch the second poll question. This is about workforce management, something that is near and dear to everybody's heart. So while we're letting the survey cook a little bit, I will mention that both actually Paul, Pat, and I recently were in the fine state of California speaking to an organization that represents the public hospitals there. And interestingly, we asked of this question. There was another answer available to them, and that was unionized labor challenges, and that was by far the biggest challenge from a workforce standpoint in the state of California. And I suspect in other states where that may be a high component of the workforce, that will be another potential challenge for them. Let's see. Do we have results? High labor costs. Yeah, I mean, and staffing ratios, recruitment and retention. Not surprising that those are the answers, given that labor is the most significant expense within health systems.
Hey, Dan, can I pick up on this question real quick, just from the rest?
Absolutely, yeah, absolutely.
We're sitting here talking about the necessity of the improved and much more robust processes on the front end. That doesn't happen without staff sometimes. So one of the things I would encourage you to look at in terms of your staffing and the workforce management in rev cycle is look at the balance of your staff across the front, middle, and back. If you have 30% or less of your staff is front end, I'm going to tell you, you don't have enough there to make the process that you need to have in place for the future work. So, take a look at those ratios across there and figure out, are you staffed for success or are you staffed for failure right now?
Yeah.
Yeah, and I'll just layer on that with I think we can expect the case mix to probably change as well with this. That those who are not seeking care will probably increase until a point where they're going to show up in your ED and they're going to show up with a higher criticality and need, which is going to require potentially a resource pool higher in your ED than it might be in other departments. And we hear this from a number of different clients of ours that the need to cross train and reallocate resources. We just talked to a client the other day. That's exactly what they're doing, is leveraging resources that are underutilized in other areas to then retrain them and put them in other areas, especially on the nursing side of things. So I think that's definitely in the short term, it's going to be, looking at the scenarios of what it could mean for you from a volume standpoint, from a case mix index standpoint, and then along the way towards that, mid to longer term planning is getting the training in place and training those resources so that you're prepared for that type of activity to happen.
And Paul, on the case mix index is going to be the interesting thing that we saw in the 2008 recession, we saw in the COVID era. Your surgical CMI is going to drop
Yeah.
because the quote elective kind of surgical cases are going to be postponed. I can't afford that. And so, my knee hurts, but I'm not going to get anything done about it. There were people that were, postponing, stents and some other, critical things that you would think you would never postpone. And yet we saw it in the data that, those kind of things got put on the wayside. So, I'm already going to be challenged in the reimbursement I get, but now I'm going to lose the reimbursement for those higher level cases as well.
Mhm.
Yeah, I'd say, I mean, one of the things that we've found, and you guys can, because we all work together, is that this historical way that organizations looked at workforce management, which was purely, worked hours per unit of service, bump it up against a benchmark. What do I need to get to median? that's really out the window. Now, really what people have to do is start to think about predictive staffing based upon, as you guys were just alluding to, case mix, acuity, where that all is. We were on a call yesterday with a client, large client, national multi-state IDN, who's utilizing tools now in the ambulatory environment to actually do predictive staffing in the ambulatory environment. So they can look ahead a week to say, in my cardiology clinic, I've got my 2 providers that are in the cath lab in the morning. I can then utilize that. I don't need to staff that the way that I staff it when they're in the clinic. I can float that staff elsewhere, and it really helps kind of do a lot of smoothing with respect to staffing. So moving away from kind of the old early 2000s type of workforce management to actual really predictive staffing. Brantley, I got a question for you, and it is on, we talked, and Pat alluded to it, right? Within kind of the dark cloud, sometimes there's a little bit of a silver lining. Are there opportunities within HR1 and the components of HR1 that can be used as a catalyst for improving payer contracting or value-based care strategies?
Yeah, I'm 100%. I spoke with a CFO a few weeks ago who their theory was, in order to absorb or react to the impact of these changes, you're going to need to think about it like 60 to 70% of our improvement is going to have to come from the cost side. 20 to 30% is going to have to come from the revenue side. And then maybe there's 10% of strategic growth. But if you hone in on sort of the revenue side of the equation, there's certainly the rev cycle component. There's also, I think organizations should view this as an opportunity to consider and go through a disciplined process to, as I mentioned earlier, rebalance enterprise revenue. And that's everything from, comparing and benchmarking our fee for service rates to market to understand if there's an opportunity from that standpoint. But then kind of a layer down from that is, evaluating kind of the portfolio of contracts that we have, fee for service versus value-based, bumped up against what opportunities exist in the marketplace. We've done a lot of work through the years to really examine, when and where should we strategically and opportunistically adopt value-based care, knowing that we have to have the capabilities on the back end in order to deliver on those contract demands. So now is as good a time as ever to start thinking about who are the right partners from a payer standpoint. How can we strategically position ourselves, demonstrate a value proposition that will allow us to try and tackle some of these opportunities from a revenue side, so that we're not just constantly trying to cut our way to success.
So Pat and Paul and all of us, I mean, we often sit in rooms and speak with CFOs. If you were sitting in a CFO's office right now, how would you advise them in thinking about scenario planning with respect to either revenue enablement or margin improvement? What type of scenario should they be thinking through in each of those areas?
Yeah, go ahead. Pat.
If I'm, talking to the CFO, the first thing is, let's figure out how good my rev cycle is right now. The reality is, everybody has focused on their rev cycle at one point or another in their career, only to see, whatever improvements I made, then we get retrenchment, and I don't stay focused on it the whole time. And so let's figure out, is there opportunity in the rev cycle as it exists right now? If I'm going to have to be in there looking at those front end processes, improving my handoffs, et cetera, let's look at all of it. Because if I've got a 5% fatal denial rate right now, that's an opportunity. I should be down at 2%. Now I'll fight the headwinds that the HR1 is going to take me back to 3%, but if that still is a net 2% improvement that can drop to the bottom line. So that's what I'm going to be looking at. I'm going to have a tougher time with cash flow. So where are my days in AR right now? In the days of low interest, even at 5-6%, people are like, it's just not as important as when it was 15%. But if I need to have that cash in the bank so I can weather the storm, let's get that cash in the bank and improve some of those kind of things. So I think it starts with, where am I right now, and what opportunities do I have to improve and be ready for this, to go ahead and tackle it from that perspective first. Paul, you were having a comment?
Yeah, I think, overall, I think hospital systems need to look at, a scenario where they're they're negatively impacted by 2, 4, 6, 8, or even 10%. And I think depending on your particular scenario, whether you're Medicaid expansion or not, as well as, what does your payer arrangement look like, to what Brantley was talking about. And we need to know at a high level, what can we expect to lose on the revenue side, in addition to everything else that we're talking about here, to take that into consideration when we're coming up with a financial imperative. And that financial imperative will be based upon those scenarios of what is most likely for the organization to need to sustain. And along those lines, that's the time to sort of put a plan in place. Short term versus long term. The short term things are optimizing a lot of things like what Pat just went through on the revenue cycle side, as well as on the supply chain side. Your existing relationships and supplier arrangements, looking at those contracts to make sure you're optimizing them as much as possible, while as planning for more midterm, long term. What can you do more strategically, more thoughtfully in the long term, to get you that extra percent or two, broadly speaking, for your organization? So, I mean, those are sort of the at a high level, the considerations. The other aspects, I've had this conversation with a number of different hospital systems, are the kind of the secondary impacts. We talk about things like on the pharmacy side, if you're a 340B eligible organization, are you near that 11.75 dish threshold? Now that your Medicaid population could potentially go down, will that have an ultimate impact on your dish payment or your dish percentage, which then could make you ineligible for 340B? So looking at those various elements that could be significant, that are kind of like red herrings, if you will, in the broader scheme of things.
Great. Thanks. Let's launch poll question number 3. This will be an interesting one. And while this is cooking, actually, one of the things that I was going to follow up on something that Pat had said. One of the things that we actually look at from an organizational standpoint is, and it was fascinating to me once Pat pointed it out to me, since I'm a simple country doctor, I don't get this whole rev cycle stuff, but we plot days in AR versus Medicaid percentage. And we're looking at an organization, and there's a direct correlation between the percentage of Medicaid that you've got and your days in AR. So it's a fascinating, although not surprising, right? Not surprising correlation. Anything you want to say about that correlation, Pat?
I mean, it's kind of, you expect the curve, but then, you look at the outlier. So, if I am heavy Medicaid, I would expect to be higher. But if I'm, even above that line, that says I've got other problems in my rev cycle I need to take a look at. And just, Paul, as you were speaking about the scenario planning, I mean, the reality is you need to start with just where I'm as a percent payer mix that's Medicaid. And, if I'm 20+%, it's going to be a hard hit. And so, you really need to make sure you're prepared for I'm going to lose some reimbursement on each of those cases as it is. B, I'm going to lose some of those cases from Medicaid, and they're going to go to uncompensated care. And so, what does my financial policy look like? What have I got for different payment programs that I can set up for that population? Because that's going to be expanding. And I've got to be ready for that in those scenarios that, Paul's suggesting we take a look at.
Right.
And your point on the 340B, I mean, I just, that's one of those that it's the different puzzle pieces. Sometimes you don't think about the intertwining of all those, but with the drop in Medicaid, all of a sudden you jeopardize your 340B as well. That's a real double whammy.
Yeah. Let's see there. Oh, interesting. Good.
I tell you this all the time, Dan.
You do. Rev cycle rules the world. So, I'll direct this to Paul, but I'm sure Pat will have want to jump in as well. So, we talk a lot in our performance transformation practice around non-labor expense reduction, because there's definite opportunities there. And we just saw in that poll result that some of these opportunities and people are focused on are in the non-labor space. Talk a little bit about quick wins in those areas. Where are some areas where organizations can start to focus and get quick wins and momentum in the non-labor space?
Yeah, absolutely. I think if we kind of go to our core areas of non-labor, so the areas like supply chain, assuming you have some type of GPO contracting, GPO relationship, optimizing that relationship to its fullest, as far as making sure that you're on the right tiers, that you're optimizing all the available contracts to you, making sure that you're getting your rebates, making sure that your service level arrangements are being met. Same thing on the purchase services side of the equation, making sure that you've reviewed those contracts and all those contracts that are out there, and ensuring that the service level that's being supposed to be achieved is actually being achieved, and if not, you're having those conversations and actively managing those relationships to ensure that you're getting the most out of it. Pharmacy, obviously, there's same type of thing on the optimization of 340B. We talked a little bit about keeping that 340B, but in and itself, making sure that you have leveraged it as much as you are allowed to, as well as looking at the optimization of specialty and your general operations. The other areas I will leave to Pat, because it seems like there's a lot of interest around revenue cycle, and I know he can hit that in spades.
You talk about the quick wins. I mean, sometimes it's just some of the very easy ones. We've had a couple examples here in the recent 2, 3 months, the lesser of provisions. And, this hits, more financial opportunity typically on the physician side than the hospital side, but there's opportunity on both sides. But we've had two physician practices that were leaving between 3.5% and 5% of their net revenue opportunity on the table, just because their prices were set below the, rate that they had in place. And their contract says, I'm going to pay you the lesser of the price or the rate. And so simply by making sure your pricing strategy is appropriate and reviewing those lesser up provisions on a regular basis, you can put more money into the organization from that perspective right away. And then, it's kind of one of my recurring themes. Everybody in the organization gets tired of me talking about it, but the whole idea of vendor management, 25% of your cash is collected by somebody else. And if all you did was sign a contract with them and hope that you're going to get good service, that's not a strategy for success. And so, to be able to manage those vendors more assertively, you're going to see improved performance right away, just because you're calling them to task to go ahead and show me each month how the metrics are moving. Show me that you've got the collection rate that I'm looking for. Show me that you're doing the right thing with returning the inventory to me after you've exhausted your efforts. Those are all things that, I eke out that last little 0.5%, 1% toward my net revenue that just gives us a little bit more, that I don't have to look at those labor things. I can keep the nurses on the floor. I can keep the clinicians out where they need to be, because I'm bringing the money in for all the efforts and services I'm providing.
Great. Let's launch the next poll question. And I'm going to go a little bit off script here and scare these guys, but I'm just going to ask a general question while this is cooking in the background. And it's around this topic. So just if you guys could just kind of weigh in on what is the role of data and technology in driving organizational efficiencies and in mitigating the effects of HR1 or other operational and financial changes. And I know we don't have to talk specifically about AI, but I think that AI probably fits into all of that. So I'd just be interested in your guys' thoughts on the role of data and technology as organizations seem are looking to drive efficiencies.
I mean, I'll get us started. I think it's everything, in a sense, from an underpinning perspective. Without the data, we're not able to understand where we should put our services, where we should put our facilities. When Brantley is trying to do those types of strategic objectives, when it comes to operations, to Pat's point, if we don't have the data, how are we supposed to actually validate whether or not those vendors are actually meeting the service line agreements that we put in place with them? If we don't understand the flow of patients through our organization, where they're going through, we don't effectively manage the overall operation. We don't necessarily put the right nurses in the right place and the docs in the right place. So I think historically healthcare systems have struggled with it, and we've implemented some very sophisticated large systems, from EMRs to ERPs, in order to help substantially in these various areas. Now we're talking about AI, and that's what everyone wants to talk about it. And I try to break it up into two things. There's AI, the way that we're currently using it, and then there's there is AI and how it's intended to be used long term. And I think we're still way, way early stages in that we're still doing sort of a call and response from an AI perspective, and that we ask AI to do something, answer something, collect something, and ultimately it gives us a really cool answer back, which is great. And that's very helpful when we're talking about, capturing notes when we're working with the patient, when we're reviewing, certain systems to make sure they're doing what they're supposed to be doing. But where we need to ultimately go, obviously, is that it's agentic AI or where it's actually thinking on its own. And that way we can elevate the resources to where they're doing the validation of what that technology is doing so that they don't have to spend the time on the minutia, but rather higher level thinking processes that we're all built to do. And I think that's sort of where we need to get to.
Let's pop up the results while oh, so somewhat or not. So, all right. Well, that's an honest group. Honest group. Pat, I'd be interested, obviously, in the rev cycle space. I've seen a bunch of data recently about the use of technology and automation. I'll call it automation, not AI, in the rev cycle space. What are your thoughts? What are you seeing as you're helping organizations?
I mean, there's some really interesting opportunities when you think about, the AI models are built on the large language model. Take all of our rev cycle transactions, every charge transaction, adjustment transaction, et cetera. That's now the large language model we're going to train them on to say, hey, 75% of my claims get paid without anybody touching them. What's different about those claims? What's on the 25%? And, I'm now paying humans to look at that 25% and figure out what do they have to change. They change the same thing every time for the same payer. Why don't we just automate that so that nobody has to touch that? And in fact, if I know I'm going to have to change it after I get a denial, let's change it before I get the denial. So I get the cash flow, I get nobody having to touch it. So, there is that opportunity. And then, Dan, I think the other place that we're starting to see some interest, and to me, it's an untapped gold mine, is just the use of agents on the front end.
Yeah.
I'm used to, I can get my hotel reservation, my plane reservation. I can do any of my scheduling stuff 24 hours a day, 7 days a week, just by going online. We have that part of the population. My mother's probably never going to want to go ahead and go online for her, airline transaction. But if I can have an agent that she can converse with over the phone to schedule her, whatever appointment, I'm opening my front door. So go back to some of what Brantley talked about. I need to look for those opportunities where I'm taking market share to make sure I can withstand some of what's going to happen with HR1. So I think, there's an untapped gold mine in looking at, where we can deploy agents and where we can employ that, learning model so that we can just keep ourselves from having to do so much manually.
Yeah. And maybe Dan, I'll throw this to you. To Pat's point, patient access. I mean, you've been talking to a lot of clients about that. And to Pat's point, like that's gonna have to be much better as we move forward, right?
Yeah, yeah, absolutely. I mean, I think what Pat was talking about is I agree. I think that the untapped gold mine is this front end agent component, and it is getting pretty sophisticated. We've met with several vendors, and we're talking about in the patient access space, in the pre anesthesia testing space, where you can have a. I mean that agent is trained on your EMR, what procedure you're having, all of your history, and it asks very pointed questions. And I mean, I've conversed with them just for fun. It is a really interesting conversation to have. And you have just, and you can have, there are different models of the ability to monitor that with a real person, or to have a very quick and warm handoff when things get a little bit sticky. But it's going to basically change the way we think about patient access. And what we used to think about patient access is that it's like open table where I can go on my phone and do it. It's going to be much more. It's going to be like you're calling somebody and having a conversation. So it's going to be exciting to watch, and it's going to change the face of ambulatory care, I think.
Well, Dan, you talk about, just what we can set up there in patient access. I mean, if everybody looks and is honest with themselves, they talk about, well, I have a call center. Yeah, and I've got 7 practices that aren't on the call center because they have so many specialized requirements. And then if I call one of those 7 specialties to try to get myself, on the schedule someplace, half the time the phone doesn't get answered. So, I mean, what am I doing for my front door? If I can go ahead and have, a true access center that, all of my availability is coordinated through that, and all these unique things where I can only do, this kind of a procedure if there's a blue moon. I mean, forget that. We've got to be out there to really, set the templates and the schedules that we can go ahead and get the throughput we need to get the margin that we need.
Yeah.
And
Let's switch gears a little bit. So let's fast forward 20 minutes and we all leave this webinar, and then Brantley gets a call from one of the people that's on this
I'm not quite sure how to help.
that's
but
attending and says, I need help with my strategy. So Brantley, how would you help boards and executive and management teams reframe their growth strategies in light of HR1? I mean, how would you advise those clients that are calling you now and saying, I gotta rethink my growth strategy? How are they going to rethink it in a smart and maybe in a way that's playing offense as opposed to playing defense?
Yeah, sure. No, I think that's a great question. And the first thing that I would say in response to that is we need to start thinking about growth and stability in maybe a non-traditional way, right? We've been this industry is slow to change and maybe not as innovative at times as it could be. So for example, thinking about value and margin creation over pure volume. What are the service lines and the high value areas where we're differentiated in the market, and how can we invest to try and grow market share and develop innovative partnerships in those spaces that are actually going to create more financial resiliency down the line. I hear a lot today about modular expansion versus linear expansion. Cost of capital is incredibly high right now. And so we're seeing a lot of organizations invest instead of in new hospital campuses. How do we expand our ambulatory presence and put up micro hospitals, freestanding EDs to continue to grow and expand our footprint without the cost barrier on the front end. We need to be thinking differently in terms of how we strategically partner with other organizations and entities throughout the care journey versus thinking we need to own every asset along the way. And I think ultimately what this situation, the environment as a result of HR1 is going to force organizations to think about is how do we approach cost transformation from a structural standpoint, within the context of an overall healthcare delivery system versus one-time cost cutting, right? So, when you think about all that, and how do you, to your next question, how do we play offense, right? Like, what are the specific strategies we should be thinking about? I mentioned earlier the whole concept of rebalancing enterprise revenue, both from a contracting standpoint, value-based care strategy, things along those lines. But we should also be thinking about things like, what are the right physician alignment vehicles that we can deploy in the marketplace to drive mutually beneficial results and improve margins in our high margin or high value service lines? What are the rural or community health partnerships that could be available or allow us to think differently or offensively, are there shared services that we can kind of spread and scale across a larger geography outside of our organization? Are there expanded or dedicated provider networks that we can develop to try and again expand reach without the upfront investment? And then sort of to the earlier theme, how do we use technology as an extension or an augmentation of our traditional care model, again, to try and guard against some of what we anticipate will be significant access challenges come down the line? So telehealth, digital front door, remote patient monitoring, a lot of the things that have been talked about and maybe not widely adopted to the point where they could be.
Yeah. And Paul, I was going to ask you this because obviously I know that we deal with this all the time. Organizations oftentimes will develop will have really good intention around their initiatives, and they'll have initiatives in a variety of different areas. What are you seeing, and what do you think are kind of best practices from a governance standpoint? Because at the end of the day, without the right governance, it's going to be really hard to actually execute on all of those strategies and initiatives. So anything that you've been seeing in the market, or anything that you would recommend if you were talking to a CEO about how they need to develop a governance process to move those initiatives along?
Yeah, it's a great question. I think, Pat and I were with a client the other day, and this is top of mind, right? Because everybody has a million different initiatives going on already. And now HR1's coming down. So now everyone's thinking about additional things that they can layer on in order to drive even more savings to the bottom line, as well as, top line revenue increases. So how do you address that? Well, it's overall management of the process. It's creating a governance model that includes those individuals that are at the C-level suite within your organization, but also include those individuals who are you're partnering with, so that everyone is on a consistent basis marching to the same drum beat. But also to the earlier conversation about data, using data as an enabler to have a common conversation and ensure that the metrics are consistent and understood across the board. The other part is that, one of the things that we always try to do is it needs to be hospital led or ambulatory led initiatives, not consultative led. And that's one of the things I think we like to bring to the table is as one of our differentiators is it's upon us to gain the support to drive this initiative forward, and but they then be presented by the client to that governance structure, so it is an internal conversation at the end of the day and owned internally as well.
Paul, I would even maybe ask a question of the group too, which is, there's governance in the traditional sense, and then is there an additional layer of governance needed to kind of drive accountability and resiliency amidst these changes? And I guess what I mean by that is we talked a lot about scenario planning on the front end, but are there additional layers of organizational attention needed in order to monitor and track the changes that are happening in real time? Because the reality of the situation is organizations are going to need to be nimble as this starts to play out.
Yeah, absolutely. I think there needs to be two things. One is the idea of cascading metrics. So those top line metrics that include the scenarios that we've outlined that say, look, guys, we need to generate improvement of 4%, 6% on margin on the bottom line. We need to improve revenue by 2% on the top line. And then those need to cascade down to not only key metrics at an operational level, but also to the initiatives. And so that those initiatives then tie to the departments, which then tie to the overall top line. And having ownership at all levels within that is obviously key as well. That's what I would say. I don't know if others have additional points though.
Paul, I think you're spot on, but the thing I would caution and suggest as a strategy as well is we've got to have data governance. I've got a client that, we typically spend half of every meeting arguing over whose facts are correct. And, at the end of the day, a patient day should be described or defined one way, and admission should be defined one way. We need to have those kind of, pieces of, just everybody, this is our data source. This is our data definition. And for those cascading metrics, this is how we're going to measure them so that we have consistency. I can actually deal fine with things that are ill-defined sometimes, as long as they're, ill-defined the same way every month. At least I get to see a trend, which is oftentimes the important piece you're looking for.
Yeah, good points. Let's launch poll question number 5. What's the biggest barrier to achieving sustainable cost reduction in your organization? We talked a little bit with this group while this is cooking is the data, or or the lack of consistency in data, the competing priorities. Paul talked a bit about that. Be interesting to see what comes out from an answer here. While this is cooking, I want each of the panelists to think, because I'm going to ask each of you after we see the results here. If you were advising a CEO, what is the top question that you would ask that they ask their leadership team going into this from an HR1 standpoint? Yeah, so each of you think of kind of your single top question. Let's see if we got results here. So we're very balanced. Wow. Resistance to change, lack of capital, limited data, competing strategic priorities. So, all right, Brantley, I'll start with you since you're left on my screen. If you were advising a hospital CEO today, what's the top question that you would tell them they should be asking their leadership team?
I think I would start with how are decisions made, right? We don't have time to get caught up in organizational bureaucracy or uh, waste time not making decisions. So I think one question that I would ask CEOs is how can we flatten decision making across the organization and embrace a culture of trust and accountability, provided that we're communicating up front what it is that the issue is. Here's the burning platform, and here's how we need to react organizationally. How do we actually make that happen in the most efficient way possible?
Pat, what would you say?
If I'm the CEO and asking all my leaders the question, I think my question would be, can you approach this with a positive attitude? The reality is, as an industry, we have faced headwinds, multiple times over. And the organizations that always come out positively are the ones that approach it with a positive attitude. You've got to be realistic about things, but if you are always looking at these things as, oh my gosh, the sky is falling, woe is us, you've just taken the energy level of your organization down far enough that we're not going to get anything done. If you go, it's time we roll up our sleeves, we'll figure out how to deal with this, we're going to come out stronger on the other end. That's a group that can get together and collaborate and get things done. So that would be my first question.
Paul?
I would probably ask, what do you see the impact that this is having to you, and what is that? And ask from their perspective, do they see this coming, or do they see this as not a direct impact? Because ultimately it does have an impact to everyone, but I'm not sure everyone within the hospital system is seeing that correlation as to how this broader effort that's moving forward is going to have a direct impact on their department or their specific role in the organization.
Good. Let's launch the last polling question. So, for the group, what areas do you feel most motivated to take action on in your own organization, given the conversation that you've heard today? And while this is cooking, I'll do the same thing I just did with each of the panelists and have them think through if they could leave this group with one final point, one guiding principle moving forward in their organization, what would that be? And let's see if we've got results.
Well, I'm going to start off with the fact that was a flawed poll. You didn't have revenue cycle as an option.
It's so I saw that, Pat. I did, and I was going to say it's in financial performance. And gosh, look at what look what happened. So leading the witness. So since you're front and center on my screen, Pat, what guiding principle, what one thought would you leave this group with?
Within every, what was the old saying? Within every crisis, there's an opportunity. I think we've got to look at this in a way to say, okay, we've been dealt a hand that we don't really want to have. But, if we put the investment of time, energy, and effort into it, we can figure out A, what's going to happen if we don't do anything. And then B, what does that mean? What do we have to do so that we come out successfully on the other end? I think that'd be my starting point.
Brantley?
Yeah, I think the leap behind that I would offer up is, and kind of sticking with the theme that I've been mentioning throughout, is don't just focus on the cost side, right? I mentioned sort of the CFO's perspective on 60% cost, 30% revenue, 10% growth and partnerships, and how they want to weather this storm. To the extent that we can, as healthcare provider organizations, focus time, attention, and drive results on that rev cycle and payer strategy side to drive top line revenue. Those are going to be kind of the force multipliers that in the end, we believe will separate the organizations who are just getting by versus those who emerge from this crisis, so to speak, better off than they were before.
Paul?
Yeah, my big advice to the clients is don't wait. I hear the complete spectrum of, well, I want to wait because maybe it won't happen. Maybe this bill won't go through. Maybe they'll reverse it in a year. The reality is change is coming, and it may not look exactly how we see it today. It might change in many different fashions or forms, but ultimately, effectively putting those scenario plans together now and aggressively making the changes only betters the organization and puts you in a position of strength versus trying to react and potentially costing your organization even more, whether it's on the revenue side or on the cost side. So it's a matter of act now.
And I'll use the moderator prerogative to add my final thought, and that's this, and this is coming from somebody who's been on the provider side, is don't be afraid to use partners. And the reason that I say that is I would always say to my executive team when we were bringing a partner in to help us with something is, listen, the reason we use partners are several. One, I know the team can do this work. I know that they've got great within your organizations, you've got the smart people to do this work. They all have day jobs, and what partners can help bring to the table is speed to value, focus, rigor, and speed to value. And so, obviously, pick your partners wisely, but don't be afraid to use partners when it makes sense to help your team. And getting to Paul's point is now is the time to act.